Today, we are diving into a really cool medical consensus that is literally creating a universal language for a disease that affects millions of people. A whole team of experts from across the Asia-Pacific region got together to build a brand new blueprint for understanding inflammatory bowel disease, IBD. And they did it right down to the microscopic level. So let's get into how they pulled it off.
Just think about this for a second. What if you had a condition, and a doctor in one city described it one way, but a doctor in another city described it in a completely different way? It sounds kind of chaotic, right? Well, this wasn't some hypothetical scenario. It was a real, everyday challenge for people with IBD. And this exact question is what kicked off a mission to create one clear standard for everybody.
Okay, so just to make sure we're all on the same page, inflammatory bowel disease, or IBD, is basically the umbrella term for chronic conditions like ulcerative colitis and Crohn's disease. They cause this long-term inflammation in the digestive tract, and figuring out just how severe that inflammation is, well, that's absolutely crucial for treatment.
And that brings us to the first part of our story, a microscopic puzzle. See, for years, doctors in the Asia-Pacific region were staring down a huge hurdle. They were all looking at the exact same disease, but they just weren't speaking the same language.
The big problem was inconsistency. Simple as that. When pathologists, the doctors who study tissue samples, looked at them under a microscope, they just didn't have a standard way to report what they saw. And this wasn't just some academic debate. It created real-world confusion that could directly mess with a patient's treatment plan. And this slide, wow, it just lays out the problem so perfectly. On the left, you get this super vague report, some inflammation noted. I mean, what does that even mean? How much? What kind? Is it a little? A lot? Now compare that to the standardized report on the right. It's precise, it's detailed. You can actually do something with that information. This is the kind of clarity they were fighting for. The whole field at the heart of this is called histology. It's basically the study of our tissues and cells under a microscope. So you can think of it as the language doctors use to describe what's happening deep inside the body. The goal here was to create a kind of universal translator for the histology of IBD.
So who do you get to take on a challenge this big? Well, that brings us to our next section, assembling the experts. A pretty remarkable group of specialists decided to come together to solve this puzzle once and for all.
And yeah, this was no small team. We're talking about 26 top-tier doctors. You've got gastroenterologists who actually treat the patients and histopathologists who analyze the tissues, and they came from 10 different countries and regions. Their one shared mission, all organized by A-Page, was to finally get everyone on the same page about how IBD was being reported.
They used this really intense process to do it, called the modified Delphi method. This wasn't just a friendly chat in a conference room. No way. They would draft statements, then vote on them anonymously. Then they discuss the results, revise the statements, and then vote again, sometimes up to 3 times. This process makes sure that the final agreement is a true, solid consensus, not just, whoever has the loudest voice in the room. So after all that work, what was the magic number? This, 37. Out of 38 statements that they voted on, they reached a consensus on 37 of them. That created this incredibly powerful new set of guidelines ready to start improving patient care pretty much immediately. So let's get into the heart of what they accomplished, this common language that they built with those 37 statements. What did they actually agree on? First, they had to define the absolute basics. Histological activity now has a very specific meaning. It's the presence of neutrophils, which are kind of the body's first responder inflammatory cells. Chronicity means signs of long-term damage. And maybe most importantly, histological remission, the big goal of treatment, is now clearly defined as no ulcers and none of those key inflammatory cells. Now, everyone knows exactly what they're looking for. And this slide is brilliant because it shows just how practical they were being. See, there were already a few scoring systems out there, like the super detailed Gibos and Robarts indexes, and those are great, but mostly for research. For everyday patient care in a busy clinic, the panel recommended the Nancy Index. And why? Because it's simple, it's reliable, and it's been validated. It just works. They even standardized the very first step, how you collect the tissue sample in the first place. This simple 4-step protocol is so important because, garbage in, garbage out. If you don't start with a consistent sample, there's no way you can get a consistent diagnosis. This makes sure everything is reliable right from the very beginning.
But the experts didn't just stop at the present day. They were also looking ahead to the future. And that brings us to something really exciting, the rise of AI pathologists.
And the most important point is right here, in this quote from their paper. The goal of using artificial intelligence is not to replace the human expert. It's to give them a powerful new tool, a kind of super assistant that can make their work better, improve their accuracy, and help with the more repetitive stuff.
And the potential for AI here is just massive. It can help make diagnoses more accurate, it can speed up the whole workflow, and it can even help with the critical job of detecting early signs of cancer, which is called dysplasia. And just to give you an idea of how powerful it is, one study found AI could spot disease activity with 89% sensitivity. This is tech that can make a huge difference.
So what does all of this common language, the scoring systems, the AI, what does it actually mean for patients? Let's bring it all together in our final section, Better Care, New Questions.
Because, look, at the end of the day, this is not just an academic exercise. Standardizing the microscopic language of IBD has a huge payoff for the people who are actually living with this disease. It leads to clearer diagnosis, more consistent monitoring, and ultimately, better and more personalized treatment.
And here it is. This is maybe the single most powerful takeaway from all of this. A big analysis they cited found that patients with ulcerative colitis who reach that deep, microscopic level of histological remission see a staggering 63% drop in the risk of a clinical relapse. That means fewer hospital stays and less need for surgery. I mean, that is truly life-changing.
So the big point here is that this whole consensus helps redefine the finish line for treatment. The goal isn't just endoscopic remission anymore, which is just what a doctor can see with the camera. The new ultimate goal is mucosal healing. It's a much deeper level of remission that combines what the eye can see with what the microscope reveals.
And that leaves us with one final, absolutely fascinating question, the only one that these 26 experts could not agree on. If a patient is feeling totally fine, but the microscope still sees inflammation deep down in the tissue, should doctors step up their treatment? It's a huge debate about risk and cost and quality of life, and it's the next great puzzle for doctors and patients to figure out, together.